plan of digital slides and drawings to the patient. So you want to use these tools to share with the patient or patients. And we're all familiar with computer imaging, which a patient comes in with a particular inquiry about what can you do? Can I do about my yellow teeth and my front teeth are shorter than my teeth on the side? And this is the way she came in, this is the way her teeth look, and she's got a reverse smile. I mean, when you look on your phone and you see that little icon of an unhappy face, it's got a reverse smile. Her teeth were organized in a reverse smile, didn't follow the line of her lip. So we could do computer imaging on a computer in about 15 minutes. I could make her look like the way I think I could make her look. And then she sees it, and then she says, okay, when can I do the treatment? I'll start. Now that is many times moving to a patient is digital, computer imaging. However, the young lady who came in and who had to wear from 4 years of college, said, gee, I can't see my teeth when I'm just talking. And I said, okay, well, we'll computer image there. I said, look, this is what we can do. And she said, oh, well, she came in with her mother, and she said, or her mother said, well, we'll go home and talk to Dad. So I said, well, wait a minute. And so I said, let's do a mock compositor. So the computer imaging has its limitations. I mean, some people will see that and they'll be convinced to the point of taking action. And in this situation, it wasn't until we actually did a mock composite, we put composite on the incisal edges of the teeth, and it was just temporary because before we even took this photograph, I think it's going to... Before we took this photograph, it had fallen off. So, I mean, it's a temporary thing, but you can see that it's built up on the incisal edges, and she could see what she looked like, and she kissed, and that's something, she was very happy. And she scheduled appointments. Now I had to call and figure out how I was going to do it with the, because there's issues to this case. So, okay. So, the fourth step is to transfer the digital information to the model and communicate with our technicians or our laboratories, our dental laboratories. And again, we'll just take a look at this case. How do we get from here to there and give, what we do, what this whole presentation is about is to give our laboratory spatial references rather than just study models. To give our communications facial references. So when you communicate, an orthodontist, see that it basically sends you a facial reference as well as a dental reference. And the facial reference tells you how the teeth are with the lips. The technician, in this instance, and this shows the lips, and there's just a number. It's what, as I said, you want to pick and choose what it is that's important to you. I mean, if you want to tell a laboratory that the teeth that he made, when you do a try-in are canted this way, and you want to demonstrate right on the porcelain how you want the teeth to be angled, and then you can write on the text in either PowerPoint, and you just do a mock composite right on a bisque try-in. And you're using the horizontal reference plane, the midline, and the incisal plane, all while you you do it either you can draw it if you think it's important, or you could just look at it and identify it. And now let's take a look at what digital smile design is from another vantage point, which is case types. I mean, we have the key concepts. The key concepts we want to apply as needed, and the case types include situations that we're all familiar with, which is simple to complex cases, but biological and functional needs. Anything from a diastema closure or a diastema space. Do you do orthodontics? Do you do bonding with composite? Do you make a little ceramic pieces and cement it on? You have to make these decisions. But having the technical know-how to treat all these things is important. But what the digital smile design concept and these tools allows you is that knowing how to transfer the information is as important, whether it means transferring it to your laboratory or your interdisciplinary colleagues. Just as important as knowing how to do the treatment. And we made a little checklist of the case types. It's the last blizzard. This is our assistant in our office, Carla. She said her daughter's getting married, and can I fix this little chip? And I said, sure. And, well, how did you do that? Eric really taught me a lot, he did. So, you can see that when you look at this, you can see that the incisal plane, although it's parallel to the horizontal, it doesn't follow the contour of her lip. It's worn flat. Whereas what we gave her was followed the contour of her lips. You can see that she had some mild crowding. We were able to fix the chip that she came in for, and we also, another thing we do is we want to look at, she's holding a little mouth mirror. You want to tend to minimize the patient holding a mirror and looking at their teeth from a perspective that they're not likely for anybody really to see it that close up, but to see the global picture, and as a dentist, to look and see what the patient sees. So, another case type, and this patient has a midline, has an incisal plane that is too short, and the midline is off. To the occlusal plane, her lip support, she's under supported by her lip, and the color of her teeth was not what she was looking for. So we applied the digital Facebow and the incisal plane to that portrait. Now, many times patients will you'll take that photograph, and you notice that this eye and pupil is at a different height to the horizontal. It's not level. So, but that's your landmark. That's your benchmark. So what you'll do is you'll use either Keynote or PowerPoint, and right in there you go to the help menu and you say, how do I rotate a picture? And it'll tell you. And so what you do is, there it goes, it just rotated. I don't know if you can see it in the back. And then you can actually use the same reference point, the interpupillary line, in all your communications. Now this patient, the color of his teeth was pretty yellow. And it looks like, okay, what do I need digital smile design for that? All I got to do is replace the teeth, with white teeth. But here it becomes very important because what he has here, and his midline is off a bit, what he has here is that you want to make sure that you give him back, nice straight teeth and an incisal plane that matches what he had. So you need to be cognizant of digital smile design there, so you can give him what he came in with, as far as the incisor position, and the length of his teeth. And needless to say, is the white-pink discrepancy. When you want to go, when you have a lot of gingival tissue here, you want to outline where you want the gingival tissue is, or where it is now, where you want it to go, and you can design it. And that's another level of sophistication that we're going to table for discussion tonight, but to include it. But the basic idea, if someone comes in and they look like that, and he didn't even come in first because of aesthetics. He came in because the upper bridge kept falling out. And but certainly when you get all done with him, you don't want to, and these are all the things of the case issues that you're concerned about, but you want to be able to give him a proportioned teeth. And by using, we're going to talk about the digital ruler, but when you give him teeth that stay in, which was his chief complaint, that they meet the criteria of what you can garner from your photographs, which is the horizontal plane, and you can get the midline, you can see the midline, and the incisal plane. Now that allows us to do the analysis, a patient analysis, a smile analysis, and we're going to talk about how you transfer that to our dental laboratory. And there's cases that come, we see that they have almost no landmarks to start with, and we have to find where to put them, and we take those, use the digital Facebow in the same concepts, and we do it to start, we do it with the laboratory, and we do it during treatment, so that when we look at the patient from multiple views, that the teeth, because I'm basically talking about a facial view, and what I'm saying in the facial view, also, you also want to take side views. I'm not even going there, but there's similar parameters that you want to establish for side views. When you look at someone from the side, the planes of their teeth, but that's a subject for. So, this isn't to say that intraoral photographs aren't important. I mean, someone that has an arch form like this, we want to decide what the arch form is going to be. And the arch form needs to be developed by having a view of the palatal view. And the palatal view in which you're going to give the patient is significant and needs to be communicated. And again, this type of this view is important. Now, maybe some of the other views, those 62 views that Christian Coachman I showed you, though you wouldn't necessarily take all those views if you didn't need them in a particular case. And you can see here that there was a canting issue, a tooth proportion issue, and in order to decide what you want to do and communicate it to the patient and do everything, you really needed to have photographs so that you could look at it, decide what to do, and present it, call in your interdisciplinary colleagues, and gather the support that you need to do the case. And needless to say, this is a physician who came up from Brooklyn and to do his upper and lower teeth. I mean, it used digital tools that were beyond the scope of what I'm going to talk about tonight. So we're going to thank Bill. I'm going to show Bill what we did with a very nice patient that he referred over, and let's design this smile for this young lady, Jessica, and make her happy. And her mother came, and you have the three views we talked about: smile, intraoral, and then portrait. And the chief complaint, which we already mentioned, this is the extent of wear that she had. She's got short roots to her teeth, small rooted teeth. And quite frankly, it made me a little, but I wasn't comfortable. When I first looked at the case, that I was going to bill me for. I said, I got to do good. Okay. So, so the other aspect of the case is that the wear predominated the maxilla. There's a loss of tooth structure. So the question came to mind, is there a loss of tooth structure and overclosure, and therefore a loss of vertical, or have the teeth super erupted as the wear occurred and there's really no closed or vertical, and I'm going to go in there and restore the case and try to put restorative materials in there and find out that I really can't open the vertical. And now I've got all this work invested in doing it, or maybe a little bit of both happened. In addition to the fact she developed was developing joint symptoms of temporal joint discomfort in the right side. So I took the leaf gauge concept, and the leaf gauge concept is to enable you to find centric relation, especially a patient that has an accommodated occlusion from wear and bruxing. They tend to wear their teeth and they get so comfortable in the position that they wear their teeth to, it's hard to find their centric relation position. So a leaf gauge acts as a lucian jig, which you place between the central incisors and you gently guide the jaw close and they slide back. Well, you take the leaf gauge, it has maybe 20 leaves in it, and you put in one and you slide them back and you ask them, well, do you feel any contact in your posterior teeth? And this young lady said, yes. I put 2 leaves in there and I guided her back. You would think she would slide her back and she would be discluded, but she would bang into some cusp. And it took 10 thicknesses of the leaf gauge to slide her back into a centric relation position so that she made no contact on her posterior teeth. Now, that doesn't sound very exciting to talk about all this occlusion, I suppose, but on the other hand, you do want to think about this. So I said, you know, I want to mount this case up and take a look at it before I do anything. And so I took a Facebow, and you notice that the Facebow, that the black line here is in the horizontal interpupillary line. This black line here is parallel to the horizontal. And you notice that the Facebow tends to go downhill, and this black line is parallel to the Facebow. So now when you take the Facebow and you put the Facebow, the maxillary cast on the bow, and you mount it, and this bow is lower, this side of the bow is lower than this side. When you mount it, you raise this up, and what happens? Does anybody know what happens? The cast gets mounted crooked. Right? I mean, you're getting some approximation of the arc of closure, because you know this is approximately where the hinge is. So then you take the leaf gauge out, and then you look to see where the contacts are, and you took 10. So centric relation is in order, you want to have no tooth contact, posterior contact. When you locate centric relation, you know the reason that the Facebow is canted like this is because of the asymmetry of faces. And the ears tend to be, and you can look at this picture of Ronald Reagan. This is his photograph, the right side and the left side. If you put this picture, take a mirror image of the picture of Ronald Reagan, and you put the 2 left sides, he looks like that. And if you put the 2 right sides together, he looks like that. So then but if you start with the original, his ears will be different from one side than the other, where the eyes tend to be parallel to the horizontal. And same thing with Marilyn Monroe. So when you take this Facebow, and now you're getting to transfer the information from the facial references of your photograph, and when you view the facial view is what you see. A facial view is what you see when you see a person standing up. So that's a facial reference. You take that, you want to transfer that to your dental laboratory. You take the Facebow, you put the Facebow onto your articulator. You have an idea that you want it to be parallel, the cast to be parallel to the horizontal. But because your Facebow is not parallel, and you take the Facebow and hook it up to something which is the hinge of the articulator that is parallel to the horizontal, what happens? Now watch this, folks. you have to rotate the cast so it's not parallel to the horizontal. And what happens is you're in trouble. Because this isn't her teeth, by the way. This is an article written by Morley and Eubank years ago about what happens with when you have canted teeth. It's probably one of the most unaesthetic things you can do when you make restorative dentistry. A midline discrepancy, an orthodontist in the room will attest probably to the fact that if you don't quite get the midline right on, you can be up to 3 millimeters before 3 to 4 millimeters before it's perceived as anesthetic. But a canting, a little bit off in the canting in a case is a problem. I mean, it's deemed unaesthetic. And this is a similar thing with the bite stick that is many times replaced the Facebow. So we want to integrate our work, basically our function, the functional as well as our aesthetic facial references. And we need to know where centric relation is. And we take our intraoral, our smile, and our portrait views, and we take several of them so we can pick and choose the one that's going to show representative of what we want to show. And we take these full portraits, again, not at the exclusion of intraoral views, and